Good afternoon, everyone. Dr. Shaini Redna, second year PGT.
I am Dr. Anam Imran, first year PGT.
We hope you enjoyed the lunch break and feel refreshed. While the afternoon hour is traditionally known as siesta time, the caliber of our upcoming session is guaranteed to keep us very much awake and inspired.
We are now entering the second half of our workshop on bioethics. This session is particularly crucial as we bridge the gap between the ethical theory and the practical realities of research in our field.
To begin our afternoon session on ethical issues in homeopathic research, we are honored to have with us a personality who stands at the forefront of clinical research and policy.
Indeed, our next speaker is Dr. Abhijit Dutta, Research Officer Homeopathy at the Ministry of AYUSH, Government of India, working at the intersection of clinical research, policy, and integrative medicine. He has authored more than 75 publications in peer-reviewed journals and has the expertise in systematic reviews, meta-analysis, evidence-based homeopathy, and the application of artificial intelligence in healthcare.
He contributes to national and international policy dialogues and has been involved in advancing research standards, including the development of reporting guidelines such as speech statement. His current work focuses on AI-driven clinical decision support and data mining in homeopathy.
Sir, we invite you to take over the session. Thank you.
Thank you very much. I think I'm audible, right? Am I clearly audible? Am I clearly audible?
Yes. Yes, sir.
Okay. Let me share my screen first. Yes. Can you see my screen?
Yes, sir.
Okay. So I'm recently feeling too much familiar with DND Homeopathic Medical College because back to back, just a week back, I have delivered a lecture on AI. So it was too short duration in between that I am appearing again. I was really thinking that whether student would be liking to see my face again or not, because they want to see new ideas, fresh ideas with some persons who are working in that field per se in its great extent technically. So, anyways, the hurdle was given to me was to discuss about ethics in homeopathic research. Although I have conducted a couple of trials earlier, including the double-blind randomized trials, and the things I have faced were really critical. Okay, so let me discuss about those things first, and in each and every slide, I will discuss about certain kind of implications of the research we are conducting nowadays. Okay, basically, just imagine if a pharmaceutical company ran trials the way homeopathy trials are run, regulators would have rejected the dossier. Let me tell you again. अगर कोई भी फार्मेसी कंपनी मतलब एलोपैथिक फार्मास्यूटिकल कंपनीज इस तरह से ट्रायल करता है जिस तरह से होम्योपैथी में यूजुअल ट्रायल्स होते हैं, देन उनके जो ट्रायल्स अगर हमारे स्टैंडर्ड्स के बेसिस पे होने लगे, then most of the regulators would have rejected their dossier. Just think about it, what kind of trials we are conducting nowadays, except a few. I'm not saying that each and every trial in homeopathy is kind of bogus. No, not like that. There are many trials which are happening in a robust manner, but there are also many trials which are facing evident manipulation, which are facing in-house data manipulation processes, which are facing some, I do not say unethical, but some lack of ethical concerns. So we will discuss all these things together so that we cannot repeat those mistakes again and again in our clinical settings and in our research settings, right? So now question is, why bioethics matters in homeopathy? People might say that ये हमारे बहुत ही पुराना एक कहावत है कि homeopaths of well conversant with research often say that homeopathy में research की क्या जरूरत है, हम पेशेंट देखेंगे, पेशेंट को ठीक करेंगे. सेकेंड एक सेट ऑफ पीपल है वो ऑफन सेज दैट रिसर्च तो सब कुकिंग हो जाता है, मैनिपुलेट हो जाता है, पेशेंट ही असली चीज है. थर्ड एक कैटेगरी ऑफ होम्योपैथिक फिजिशियंस है, दे ऑफन से दैट रिसर्च मेथोडोलॉजी जो एग्जिस्ट करता है, द एग्जिस्टिंग फ्रेमवर्क ऑफ रिसर्च मेथोडोलॉजी डज नॉट रियली अप्लाई टू होम्योपैथी. व्हाई शुड वी अडॉप्ट दैट? नाउ द थिंग इज, इन सब आर्गुमेंट्स का कोई वैलिडिटी प्रैक्टिकली है भी कि नहीं, वी विल टॉक अबाउट दैट एज वेल. ओके, नाउ जो बायोएथिक्स है, why this bioethics matters in homeopathy, that is a very legit question, and thank you for conducting this seminar, because I know there are many stalwarts who will be speaking after me and who have spoken before me. But the thing is, from the homeopathic perspective, without any of sugarcoating, I will tell you the raw truth that we are facing nowadays, and that how it is hampering, how it is affecting the homeopathic policy making. I will also discuss about that, because my current role is basically making and contributing to the international policies from the government of India in terms of all the AYUSH systems of medicine. So I will also tell you what is the policy implication of this bioethics consideration in homeopathic research and how it is currently being implemented. Now, let me show you the global scenario of that. As you can see that almost 200 million patients use homeopathy globally. Okay, 80 plus countries have regulatory framework for complementary and alternative systems of medicine, including homeopathy. Annual homeopathic market in Europe alone is more than 1 billion euros. Just think about it. Okay. Now, the debate is, scale of homeopathic use is not trivial. ये कोई 1-2 करोड़ रुपए की या 1-2 करोड़ इंसान की लोगों की बात नहीं है. The scale of homeopathic use is not trivial. 200 million users means any ethical failure in research or regulation has a population level consequences. यहाँ पे अगर हम एक गलती करते हैं तो it will affect 200 million people who are using homeopathy. And this is not a niche academic debate, it is a mainstream public health question. And the core ethical problem is when millions of patients choose a treatment whose evidence base is contested. Contested means, I'm not saying that there is no evidence base for homeopathy, although many systematic reviews are saying that. I am saying that homeopathic evidence base is too much sparse, too much diverse, too much heterogeneous, and because of some lack of insights or regulatory insights or policy insights or bioethical insights, these trials are remain contested. Until date, we are struggling to prove that homeopathy affects beyond placebo, right? And as you can see in many of the systematic reviews, meta-analyses, it may be Kukerat, it may be Shang et al., it may be NHMRC report, it may be NHS's own review. All these reviews are saying the same thing. Some are positive, some are negative, although, but almost all the reviews are saying same thing: heterogeneous quality, inconsistent blinding, and high risk of bias. These are mostly running all through the homeopathic trials. Although nowadays we are getting some good quality trials having low risk of bias or moderate risk of bias, but these trials are also underpowered. I mean, not adequate sample size they are meeting up, right? Second is, here high patient use. Some people are saying that homeopathy we have I have treated hundreds of patients. I am treating hundreds of patients in my chamber, in my clinics. But actually, high patient use is not evidence of efficacy. It is the evidence that the ethical stakes are very high. Whenever If you are working with 3 4 people, doesn't matter. But if you are working with 300 people, 400 people, it means that 300 400 families matters. As you can see in this map, this is the homeopathic revenue generation worldwide. Market size is almost $3 to $4 billion. And as you can see that India, US, Canada, Brazil, many of the European countries, including Germany, alone constitutes more than $2 billion of market size. So if this much revenue is at stake, if this much revenue is homeopathy, what it is actually generating, that we must be very much serious about the consequences of our action or our trials. Now you can see that rising scrutiny and controversy, there are some regulatory aspects, there are some scientific criticism. मैं ये नहीं कह रहा कि सारे report were unbiased. Many of the reports were quite biased and tilted against homeopathy. But as you can see that Australian NHMRC report, which is almost latest report, and after NHMRC, the second report has also come, third report, sorry, who found no reliable evidence of effectiveness beyond placebo. Although its first report has been released, and it is also saying the same thing, but not in that negative way, little positive way. UK House of Commons, as you know, that recommended NHS funding withdrawal. अच्छा, यहाँ पे एक बहुत ज्यादा negative notion है, people saying that homeopathy is getting banned in foreign countries. No, actually it is not. Homeopathy is not getting banned in foreign countries. Their fundings are getting withdrawal from the insurance or from the government funding. So that is happening because of these reports, or rather to say very robust systematic review and meta-analysis reports. But homeopathy ban আজ পর্যন্ত কোথাও হয়নি. If it is the question of ban, then no, it is not. It is the question of funding withdrawal. But in those countries also, many private players are doing very well and having billions of dollars of business. Okay. But the thing is, if you ask my opinion about these reports, including Shang et al., NHMRC, Matthew's report, all of these reports, some reports have adopted different methodologies. But if you ask my opinion, then as for my opinion, yes, it is true that there is very unreliable and low quality evidence we have in our hand nowadays for homeopathy. And the scenario has not very much changed in past few years. Now, objective of this presentation is, first, we will map the ethical terrain, identify the unique bioethical challenges inherent to homeopathic research designs and conduct. Especially, I will be talking about mostly RCTs and other clinical trials. Second one, we will interrogate the evidence ethics tension, that how evidence is working and how ethics has to be conglomerated with that. Examine whether weak or contested evidence creates some ethical obligation rather than excuses. Third is analyze regulatory gaps, critically assess the global regulatory frameworks of CAN and their ethical adequacy. Fourth one is propose an ethical framework, that how this actionable principle based guidance for research regulators and journals can be created. And fifth one, we'll talk about stimulate critical dialogue. I will ask you some questions, not to answer, but to think. Now, what bioethics teaches us? There are 4 basic core principles. One is autonomy, where respect individual decisions capacity, right? Autonomy is respecting individual capacity. Here, the question comes, is a patient's choice truly autonomous if they have not been told that the evidence for intervention is absent or weak? Suppose এই কোয়েশ্চেনটা অনেকেই ফেস করে. A layman will ask you, is there any treatment for thyroid in homeopathy? Then the answer is very much fascinating of the homeopaths. আমরা কি বলি? না, আপনার কেস টেকিং করতে হবে, we will take the full case of you, we will take the full history of you, then we will do the totality of symptoms, then we will individualize the case, then we'll give you the medicine. And if the patient says that I'm having iodine 30, then we will say, okay, it's fine, iodine 30 খেলে হবে, but we will take the case and see that iodine হচ্ছে কিনা, তারপর আমরা তাকে ইন্ডিভিজুয়ালাইজেশন বোঝাতে শুরু করে যাই যে we compare him with other patients of thyroid, then we absurdly used to say that we have cured 30-40 cases of thyroid, I mean hypothyroidism. All of these things we discuss, but we never say the direct answer whether there is any treatment of thyroid in homeopathy or whether there is any treatment of hypothyroidism in homeopathy. So direct question does not have direct answer. Do you know why? Because we don't have the clear cut evidence whether really homeopathy works in hypothyroid cases or not. Maybe suppose we have some 5 6 high quality, very high quality randomized control trials where you have either used individualized homeopathy or used clinical homeopathy or used isopathy or used complex medicines, whatever it may be. If we have this 5 6 high quality adequately numbered RCTs with low risk of bias, and we are having moderate to high great certainty of evidence, then we can clearly say yes, there is treatment of hypothyroid in homeopathy. But the question is, do we have that evidence right now? No, we don't have. Now, the question is, when we are doing some clinical trial, the bioethics principles autonomy says that we have to explain to the patients that existing trials does not say that homeopathy has effect beyond placebo, but our individual case report says that it works. But we don't know for your case it will work or not. So this is the clear communication to the patient, and this clear communication is known as information that has to be provided to the patient to have the informed choice. So whenever you are taking consent form signed by the patient, যখন তোমরা consent form নিচ্ছ পেশেন্টদের কাছ থেকে সাইন করিয়ে, do you really explain what you are going to do with them? Do you really explain what kind of existing therapy are there? Do you really explain that what kind of consequences or harms that are evident? Do you really explain that what kind of best possible therapies are already existed, but you are refraining them from getting it? যে হাইপোথাইরয়েডিজমের জন্য এলটক্সিন আছে, বাট আপনি ওটা খাবেন না বিকজ 3 মাস আমরা দেখবো যে এই মেডিসিনে আপনার কাজ করছে কিনা। ডু রিয়েলি এক্সপ্লেন দেম? হার্ডলি। I have not seen anyone explaining them like that. So autonomy is somewhere getting harmed here. Okay. Second is beneficence. It says that can we claim to benefit someone with a treatment we cannot demonstrate works? সাপোজ একটা এলএম পোটেন্সির মেডিসিন আমি পেশেন্টকে দিচ্ছি, যদি পেশেন্ট জিজ্ঞেস করে যে এটা কিভাবে কাজ করে, ডু ইউ হ্যাভ দ্য আনসার? উই হ্যাভ টু হ্যাভ দ্য আনসার, সেটা যেভাবেই হোক, but it will help the patient to get the informed choice. Non-maleficence, harm is not only about direct toxicity. আমরা বলি না যে হোমিওপ্যাথিক মেডিসিনের কোনো সাইড এফেক্টই নেই। সো পেশেন্ট ভাবে ওকে ফাইন, আমরা নেব, হলে তো এফেক্টই হবে। সি নন জুভাট মোডোনিন ওসিয়াট, if it cannot do good, it cannot do harm, it will not do harm, right? Hahnemann clearly said in Organon of Medicine, see non-juvat mononin ossiat. But the thing is, if you see this perspective in a different way, then you can see harm is not about direct toxicity. কি মেডিসিন খেলে টক্সিসিটি হবে তাহলেই ওটা হার্ম, না হলে নয়, এটা নয়। Harm is also about false hope, delayed treatment, and financial harm. All counts. If you are giving him false hope, you know that patient is not improving after 3 4 6 months of your treatment, but you are still giving him the false hope, আরে ঠিক হয়ে যাবে, ঠিক হয়ে যাবে, এক বছর তো ট্রিটমেন্ট করান। You are delaying some good therapy for the patient and financial harm. প্রত্যেকটা ভিজিটে 400 টাকা নিয়ে নিচ্ছে পেশেন্ট থেকে। These are also non-maleficence and justice, or maleficence, sorry, and justice. Who bears the burden of the research participation and who controls the evidence that produced from it? So fair distribution of the research burden and benefits, protecting vulnerable population from exploitation. I have seen one trial where there was not at all any consent uh, obtained from the children's parents, but the clinical trial is completed. But in her ethical ethics committee review, it was clearly stated that assent will be obtained, but it was not. So see, what we speak about during our ethics committee review and what we do in the clinical real life, there is a very big gap. And this is where bioethics comes into the play. Always what you write is not what you actually conduct. Now, if you see the homeopathic research landscape in PubMed, if you search homeopathy, I mean, homeop, wildcard, and homoeop wildcard with title filter. If you search that, you will get around 169 case reports, 66 systematic reviews, in vitro basic study about 101, observational study about 61, and RCT is only 249. So here, whenever we ask for scientific credibility of homeopathy, people says that we have hundreds of RCTs. No, actually it is only 249 for the PubMed index. তাছাড়াও তো এদিক ওদিক অনেক হয়েছে, but PubMed index is 249 till date. And in that also 66 systematic reviews have been done. Just think about it. Trial হওয়ার আগে systematic review complete হয়ে যাচ্ছে, because many people wants to see, they're willing to see that whether homeopathy works or not for various conditions. And suppose I am saying, for the argument's sake, that we have good volume of research. Now, second question is, does research volume equals to research quality? No. Quantity of publication masks severe methodological limitations. If we do Cochrane-Riskov bias second version tool, if you apply it in these 249 RCTs, it's my assumption, I have not done it, but it's my assumption it will only lead to 15 to 20 very low risk of exactly low risk of bias studies. Now there is an epistemological tension where we will discuss about science versus tradition. So what the traditional knowledge we have, vitalism, miasm theory, and like cures like, or other 7 cardinal principles, whatever it is. Then empirical observation we have, case-based evidence, patient outcomes, and then RCT or EBM standard we want to follow, that randomized control trial or evidence-based medicine standard, right? Now the thing is, epistemological humility is not a scientific realism or scientific relativism. You know why? Because homeopathy has epistemological basis, right? We have very big chunk of philosophy, we have very big chunk of philosophical support, material symptoms. But here, Thomas Kuhn's paradigm concept applies. Homeopathy operates within a distinct framework of anomalies and explanatory logic. And the EBM hierarchy, that is meta-analysis, more than RCTs, more than cohort, more than case series, this disadvantage individualized holistic therapeutic evidence. So the key ethical implication is weak evidence does not justify weak ethics. Rigor requirement increase, do not decrease under uncertainty. So now, in short, it means that if we have weak evidence, this just does not justify weak ethics. আমি যদি বলি, আমাকে যদি কেউ জিজ্ঞেস করে যে হোমিওপ্যাথি ওয়ার্কস ইন ব্রেস্ট ক্যান্সার, আমি বলছি না না, RCT 2-3টে আছে, অনেক RCT থাকলে বলা যেত এটা কাজ করে. So it is absurd, absolutely absurd. Always we have to speak with the language of current evidence. And if you have anything to justify, then you do it after that. Now, where ethics meets evidence-based medicine. See, this is evidence-based pyramid, little inverted. Here, it is not the traditional pyramid you see. It is just inverted pyramid with large base means large implication. So the highest strength is of systematic reviews. Then little low strength is randomized control trials, which is gold standard. Then above that cohort, case series, expert opinion. So all of these are having high grade gradually. Now EVM demands that the treatment recommendation tracks evidence. Evidence based medicine কি বলে সবসময় আরসিটি মানে হাই কোয়ালিটি, কেস সিরিজ কেস রিপোর্ট মানে লো কোয়ালিটি, এটা কিন্তু নয়। এভিডেন্স বেসড মেডিসিন, ডেভিডেল স্যাকেটস ডেফিনেশন ইজ নট এক্সপ্লিসিটলি সেইং দ্যাট, ইট ইজ মিস্টেক। যদি আমরা এটা বলি যে আরসিটি is of very highest quality and observational studies are low quality, it cannot be justified because it is designed to serve separate purposes. In many cases, RCT is not possible. Then we do observational studies. In many cases, RCT design does not fit the existing framework. In those cases, we have to seek for some alternate design. So all of these has different implications, and we adopt it like that. Okay. So now, if you say that expert opinion is of very much lowest quality, but systematic review is of highest quality, no, not like that. Evidence-based medicine says that when you are treating individual patients, if you have evidence means one of these, one of all these, if you have that, then it's fine. Okay. And suppose then you have to grade the evidence. Suppose you have high quality systematic review and meta-analysis for the evidence of effect of arnica in knee injury, if you have that evidence. So it will be given more priority than if you have single center RCT. Evidence medicine is saying that for only the treatment of individual patient, not to argue that this is good and this is bad. Okay. Now, individualization versus standardization in trials. This is a great debate. As you can see that the fundamental problem is very much structural. Homeopathy's therapeutic logic is basically inherently and irreducibly individual. Everybody knows that আমরা individualized treatment করি। Two patients with identical biomedical diagnosis, suppose irritable bowel syndrome, may receive entirely different remedies based on their constitutional type, their miasmatic history, and their specific modalities of symptoms. An RCT that gives all patients the same standardized remedy is testing a non-standard or non-representative version of the practice, arguably not homeopathy as it is actually practiced, right? Suppose আমরা যখন RCT করছি, আমরা কোনো একটা স্পেসিফিক মেডিসিন নিয়ে যদি RCT করি, it is not justified because it is not aligning with our principles of homeopathy. And in rare cases, some complex homeopathy, if you want to try and test it, no problem. But the individualization concept of homeopathy is not aligning with the general definition of RCT that all the patients will get the same symptoms. So now what we have modified into efficacy of individualized homeopathic medicine in knee osteoarthritis, suppose. But we are randomizing patient into two arms, of course. One is getting the individualized homeopathic medicines treatment, another one is getting the placebo. But we are individualizing all of the patients. Suppose 60-60 in both arms, that is 120. So we are individualizing 120 patients, but among those 60 are getting actual medicine and 60 are getting placebo. Okay. But this is having a serious implication, although we don't have any other way to do that, but we are having serious complication because in all these cases we don't know what kind of individualization and what robust the individualization were for each and every individual patient. We don't know. That's why suppose at the end of the trial you are getting result that individualized homeopathy is better than placebo. Suppose you are getting the result, you are jumping in happiness. Okay, I have got the result of effectiveness of efficacy of my medicine in individualized homeopathic medicine. So you have published the trial, it is well published in PubMed Index journal. But the thing is, it is serving just one purpose: the question whether homeopathy acts beyond placebo or not. But it is not serving the fundamental question of evidence-based medicine, that how to use that result clinically. তো আরসিটির রেজাল্টটাকে আমি ক্লিনিক্যালি কি করে অ্যাপ্লাই করব? what kind of insight I will get from that RCT? Only for scientific argument, yes, homeopathy acted beyond placebo. Okay, fine. But how to apply that clinically? What kind of clinical recommendation you will do? That is not known. So now this contested paradigms has to be connected together with certain refined methodology. And as you can see, that individualization and standardization in trials does not go in a single line. Right. Now, placebo use has a ethical debate. This placebo paradox deserves a special treatment. If homeopathic remedies works primarily through expectation, therapeutic ritual, and consultation relationship, that is, if the active ingredient is the therapeutic process rather than the remedy itself, then the placebo control trial is methodologically incoherent. Recently some trials are published where it is saying that suppose তিনটে আর্ম আছে, একটা আর্মে হোমিওপ্যাথিক মেডিসিন দেয়া হয়েছে প্লাস কনসালটেশন মিনস যে আমরা কেস টেকিং করি, পেশেন্টের সাথে কথা বলি আধা ঘন্টা 1 ঘন্টা ধরে। দিস আর দ্য কনসালটেশন প্রসেস। সো ইউরোপিয়ানস critically says this as consultation, and therapy is different. Giving the medicine is the therapy. So there are some trials that have been published, especially one in ADHD and another one is in probably osteoarthritis. So these two trials explicitly says that the benefit in the arm was also obtained where only homeopathic consultation were given. No medicine, only placebo, but homeopathic consultation were given, and patient improved. Do you know why? Because it has a psychological effect of getting better. Okay, so this is the placebo paradox. So now tell me, are we really giving placebo in that arm? No, we are also giving the consultation process, which is having a good implication on the psychological process to improve the disorder or disease. Now we are quite being criticized because of this placebo paradox. Helsinki Declaration, which is called the mother of all the ethical declarations, specifically paragraph 33 of 2013 revision or 2013 মানে 2013 সালেই হয়েছিল, 2013 রিভিশনের প্যারাগ্রাফ 33 একবার সবাই ডাউনলোড করে একবার পড়ে নেবে, specifies clearly that placebo controls are only ethically acceptable when there is no provision of effective intervention for the condition being studied. আমরা তখনই সেই সব কন্ডিশনই প্লাসিবো কন্ট্রোল ট্রায়াল করতে পারি যেসব ডিজিজে অ্যাক্টিভ প্রুভেন ট্রিটমেন্ট নেই। ফর এন এক্সাম্পল, সাপোজ amyotrophic lateral sclerosis, a specified version of MND, motor neuron disease. তো amyotrophic lateral sclerosis এ কোনো ট্রিটমেন্ট নেই অলমোস্ট, কিছু palliative treatment আছে, but they are having no proven efficacy. In that case, you can do placebo control trial, or at least placebo control design for doing some alternative form of trial because it is rare disease. Okay. So in those cases only placebo control therapy justified. But let me do a placebo control study, purely placebo control study on stroke or acute stroke. Is this justified? No. Let us do a placebo control trial on myocardial infarction. It is justified? No. When we have some life-threatening condition, it is absolute no. But when we have certain disease condition which are already having some proven therapy, then also placebo control trial is not justified. In that case, if you want to see the effect of your treatment, then do a comparative trial with that active therapy which is already proven. Open label placebo research, it was pioneered by Ted and a colleague at Harvard. They have shown a genuine therapeutic effect from placebo even when the patients are explicitly told that they are receiving an inert treatment. Just think about it. আমরা ওরা একটা ট্রিটমেন্ট মানে এক্সপেরিমেন্ট করেছিল ইন হার্ভার্ড। দে হ্যাভ সিন দ্যাট কোনো পেশেন্টকে এটা বলে দেওয়া হচ্ছে যে এটা প্লাসেবো, এটার মধ্যে কোনো মেডিসিনাল ভ্যালু নেই, আপনি এটা খান, ওটা খাওয়ার পরেও ইমপ্রুভমেন্ট হচ্ছে। সো নাও there are some articles which is clearly saying that is placebos are real placebos? Actually, no. Placebo are having certain effect as well. Okay. Now there are therapeutic misconceptions in patients uh, that has to be taken care of. Like therapeutic misconception occurs when a research participant conflates the purpose of the trial with the purpose of clinical care. Suppose আপনার কাছে মানে তোমাদের কাছে যখন পেশেন্ট আসছে ক্লিনিক্যাল ট্রায়াল এনরোলমেন্টে, you are doing a clinical trial or RCT on dyspepsia. Now patient comes with severe dyspepsia, having excessive gas, bloating after each and every meal, acidity, and you are saying to the patient that আপনি ক্লিনিক্যাল ট্রায়াল এনরোল হয়ে যান, আমি আপনাকে মেডিসিন দিচ্ছি, এটা আপনার ভালো হবে, with the purpose of clinical care you are showing, but actually you are using the participant as a purpose of trial, for the purpose of trial, but showing that it is the purpose of clinical care, right? This is also a therapeutic misconception and misleading the patient. Just now, there are some scientific plausibility and scientific plausibility is basically how the treatment works or biological plausibility. And there must be some ethical justification criteria, right? Uh, this is little tricky slide, but let me tell you in a simpler way. Scientific people ask na, that how homeopathic medicine works. So Bayesian ethics, there are two kind of basically statistics. One is Bayesian, one is frequentist. These ethics hold that resource allocated to implausible interventions carry a higher opportunity cost, right? Like water memory theory of Van Westin and not replicated under blinded conditions. আমরা বলি না যে water memory homeopathy acts to water memory, but it is not acting under the blinded condition. ওটা অনেকবার replicate করার চেষ্টা হয়েছে but হয়নি। তো এই সমস্ত কন্ডিশনস এগুলোর যে legit conclusion that has to be explained to the patient, which is the ethical justification that we can offer, right? So the question must be genuinely unresolved, not a foregone conclusion being researched for marketed purpose. মানে আজকাল অনেক প্রোডাক্ট এমন হয় যে even without any ethical approval they are getting marketed with certain criteria, although there are certain loopholes you can say. Okay, and this is another problem. We are very much under reporting, not only in CAM research, in modern medicine trial also. This is a very, very, very big problem that we are hardly reporting adverse events in CAM research. Okay, we are hardly reporting. And there are certain genuine dilemma about homeopathic trials, like individualization concept, that homeopathic practitioner lacks equipoise. They believe in efficacy. Does this makes all practitioner-led trials ethically compromised? This is a big question. আমরা এটা ভেবেই ট্রায়ালে নামছি যে এই মেডিসিনটা কাজ করবে। So does this bias also affecting our research being used for the people in future? Community equipoise, broader biomedical community does not have equipoise, and most experts are not uncertain. Does this prohibit trials? সবাই বলছে ভালো হোমিওপ্যাথি কাজ করে, so does it prohibiting the trials? If equipoise requires only one community to be uncertain, trials may process, but which community's opinion governs, that is important. So there are practical guidance that protocol should explicitly state the basis of equipoise, citing community and uncertainty rather than individual belief. There is a thing called publication bias and selective reporting. In many of the homeopathic trials, we are not publishing if it is having some bad results. So this is a big problem, not also in homeopathy, but also in other stream. But in homeopathy, publication bias is a serious factor. Okay. So there are certain challenges in RCT designs like double blinding, control selection, sham homeopathy, this placebo effect. Okay, sample size and power. We often choose underpowered trials, crossover design risks. These are the basic challenges in homeopathy. There are some observational studies, ethical trade-offs also. Like as you can see the below table, that blinded RCT, pragmatic RCT, prospective registrations, retrospective case analysis, these also are having certain ethical risk. But blinded RCT have the least ethical risk when we are communicating that to the patients. Now, safety studies versus ethical trials, different ethical obligations we are having. Safety studies are appropriate when even for implausible interventions. If the use, if the product is in use, harm characterization serves public health. An efficacy trial is requires high ethical jurisdiction, but we are having very much least of that, right? Now there are certain data integrity and transparency issues also. আমি রিসেন্টলি একটা ট্রায়াল দেখেছি, আহ, সবারই চেনা মানে একটা চেনা জানা স্টুডেন্টের ওই ট্রায়ালসটায় প্রাইমারি আউটকাম যেটা ডিফাইন করা ছিল, ইনস্টেড অফ দ্যাট প্রাইমারি আউটকাম ওটা নেগেটিভ এসছে, সো দে হ্যাভ রিপোর্টেড দ্য সেকেন্ডারি আউটকাম অ্যাজ অ্যান প্রাইমারি ওয়ান। দে হ্যাভ কমপ্লিটলি masked the outcome of the primary one, or the primary outcome as a result. So this is a big data integrity issue and transparency issue as well. So conflict of interest disclosure, statistical phishing, আমার তো মনে হয় যে পিজি থিসিস যেগুলো, they are also having conflict of interest because in many of the cases, not all students, I'm not saying that everyone does that, but in many of the theses I have seen কি কখনো নেগেটিভ রেজাল্ট বা নন সিগনিফিক্যান্ট রেজাল্ট এলে they becomes depressed. My trial got non significant result. আরে, what's the problem in it? Just publish it and find it out what kind of non significance happened. In my dissertation case, when I was doing PG in NIH, I have a stroke trial, right? In post-stroke hemiparesis trial, I found non-significant result from my primary outcome. I have reported it clearly. And I have also discussed the problem in my discussion section that what could be the possible reasons of being non-significance. So what future trials should follow to address this issue. That is the transparency and data integrity that we should follow. Now, there are certain global regulatory landscape. Everybody almost knows about it, so I'm not repeating those. There are certain ethical gaps also, double evidence standards. Okay, homeopathic products are often approved without efficacy data, and if it is not, then maximum homeopathic medicines cannot be marketed even. And no mandatory pharmacovigilance. Marketing and research claims are different. They are saying that it can reduce the rhinorrhea, it can reduce the rhinitis, but after that we are seeing that it is uh, in the research, in the clinical trial, it is not even reducing the rhinitis. It is having no effect on the symptoms, right? Then practitioners accountability. In many countries, homeopathic practitioners face no normal requirement for continuing education. In India, at least, it is legislation. A highest level of legislation is happened to be there. Like BHMS is 4.5 plus 1 is 5.5 years, even more than that. And after that, 3 years of MD. So it is quite regulated. But in many of the countries, it is not. Then pediatric vulnerability, use of homeopathy in children in for serious conditions. That raises non-maleficence concern that are under-regulated. Okay. So there are some role of government and institutions, but yes, informed consent and patient autonomy. This should require three things to be very much clear about. One is disclosure. You disclose everything to the patient. Do not hide anything or any kind of background information. Second is comprehension. Always ensure whether patient have understood you clearly or not. And then voluntarities. If after hearing all this, if patient is volunteering themselves for the trial, then include them. So it is altogether known as informed consent. Means patient is quite informed to give the consent. Okay. Okay, so almost all the things we have discussed. Yeah, just last thing I just want to say that if you use your ethical concerns and bioethical principles, and if you use your bioethical concerns properly in your, then the clinical trial will be strengthened, and that can be used to inform the policy and public health. Thank you very much for your patience hearing. If you have any question, I'd love to answer.
Thank you so much, sir, for the enlightening session. Addressing ethics within the specific framework of homeopathic research is vital for the global recognition of our system. And your insight on AI and data mining gave us so much to consider. Now I request audience, if there is any question, any queries, please you may ask. Anyone from online? Thank you so much, sir, for this great session. Any question?
লেগেছে? ये फिर से गिरेगा এটা
We'll start our next session after a few minutes. Our next speaker is on the way, so please wait for some time.